CEN Written Exams Results. Question 1. A patient presents with a sudden onset of fever, chills, and hypotension. The patient is a chemotherapy patient and has a central line. The CEN should suspect: Option A, sepsis, bacteremia. Option B, febrile neutropenia. Option C, anaphylaxis. Option D, pulmonary embolism. The correct answer is option B, febrile neutropenia. Patients with chemotherapy-induced neutropenia are at high risk for infection and sepsis. A single temperature 38.3 degrees Celsius, or 38 degrees Celsius for more than 1 hour, is an emergency. Cultures, blood, urine, sputum, should be obtained, and broad-spectrum antibiotics should be given promptly. The patient is at high risk for bacteremia and septic shock. This is a medical emergency. Question 2. A patient with a psychiatric emergency is being discharged. The CEN should: Option A, provide a written crisis plan and resources. Option B, schedule a follow-up appointment. Option C, ensure the patient has a safe discharge plan. Option D, all of the above. The correct answer is option D, all of the above. Psychiatric discharge planning is an essential part of emergency nursing care. It includes providing a written crisis plan, referral to community resources, scheduling follow-up appointments, and ensuring a safe home environment. This is part of the professional issues domain, covering discharge planning, patient safety, and continuity of care. Question 3. A patient with an orbital fracture presents with diplopia, anophthalmos, and subconjunctival hemorrhage. Which complication should the CEN suspect? Option A, optic nerve damage. Option B, globe rupture. Option C, entrapment of extraocular muscles. Option D, all of the above. The correct answer is option D, all of the above. Orbital fractures can cause entrapment of extraocular muscles, leading to diplopia and restricted eye movement, anophthalmos, and possible optic nerve damage or globe rupture. A thorough ophthalmological examination is needed. CT scan of the orbit is the diagnostic test. Surgical intervention may be needed for entrapment and anophthalmos. Question 4. A patient with septic shock has been fluid resuscitated with 30 ml/kg of crystalloid but remains hypotensive with a MAP of 55 mmHg. The CEN should anticipate: Option A, additional fluid bolus. Option B, initiation of vasopressors, norepinephrine. Option C, broad-spectrum antibiotics. Option D, central line placement. The correct answer is option B, initiation of vasopressors, norepinephrine. In septic shock, if the patient remains hypotensive, MAP 65 mmHg, after adequate fluid resuscitation, 30 ml/kg, vasopressors, norepinephrine, are indicated. Norepinephrine is the first-line vasopressor for septic shock. Broad-spectrum antibiotics should be given within 1 hour of sepsis recognition, and a central line may be needed for vasopressor administration. Question 5. Which finding is classic for cardiac tamponade? Option A, widened pulse pressure. Option B, Beck's triad, hypotension, muffled heart sounds, JVD. Option C, Kussmaul's sign. Option D, pericardial friction rub. The correct answer is option B, Beck's triad, hypotension, muffled heart sounds, JVD. Beck's triad is the classic presentation of cardiac tamponade, hypotension, from decreased cardiac output, muffled heart sounds, fluid in pericardial sac, and jugular venous distension, impaired right heart filling. Other findings include pulsus paradoxus and electrical alternans on ECG. Emergent treatment is pericardiocentesis. Pericardial friction rub suggests pericarditis. Question 6. A patient with frostbite to the fingers should be managed with: Option A, rapid Ruhrmeng in water at 37 to 40 degrees Celsius. Option B, dry heat, e.g., warm blankets. Option C, massage to the affected area. Option D, surgical debridement. The correct answer is option A. Rapid Ruhrmeng in water at 37 to 40 degrees Celsius. Frostbite is managed with rapid Ruhrmeng in warm water at 37 to 40 degrees Celsius, 98.6 to 104 degrees Fahrenheit, for 15 to 30 minutes. Ruhrmeng should be done until the tissues are thawed. Analgesia is needed due to pain. Dry heat, e.g., warm blankets, is not recommended as it can cause burn injuries. Massage can cause tissue damage. Surgical debridement may be necessary after Ruhrmeng if necrosis occurs. Question 7. A patient with COPD presents with severe dyspnea, confusion, and cyanosis. ABG shows pH 7.25, PaCO2 65 mmHg, PaO2 55 mmHg. The CEN should anticipate. Option A, non-invasive positive pressure ventilation, BiPAP. Option B, high-flow oxygen via non-rebreather mask. Option C, bronchodilators only. Option D, immediate intubation. The correct answer is option A. Non-invasive positive pressure ventilation, BiPAP. This patient is in acute respiratory failure with hypercapnia and acidosis. BiPAP is the first-line intervention for COPD exacerbations with respiratory acidosis, as it can reduce the need for intubation. High-flow oxygen should be used cautiously in COPD patients to avoid suppressing the hypoxic drive. Bronchodilators should be given, but BiPAP is the priority for this acidotic patient. Question 8. What is the correct compression to ventilation ratio for adult CPR with an advanced airway in place? Option A, 30:2. Option B, 15:2. Option C, continuous compressions at 100-120/min with breaths every 6 seconds. Option D, continuous compressions at 80/min with breaths every 8 seconds. The correct answer is option C. Continuous compressions at 100-120/min with breaths every 6 seconds. When an advanced airway, ET tube or supraglottic airway, is in place during adult CPR, continuous chest compressions at a rate of 100 to 120 per minute are delivered without interruption for ventilations. 1 breath is given every 6 seconds, 10 breaths/min. The 30:2 ratio is for CPR without an advanced airway. Question 9. A patient presents with a severe headache, nausea, and vomiting. The patient has a history of hypertension. Which finding would suggest a subarachnoid hemorrhage? Option A. A sudden, severe headache, thunderclap, and nuchal rigidity. Option B, gradual onset headache. Option C, blurred vision and photophobia. Option D, focal neurological deficits. The correct answer is option A. A sudden, severe headache, thunderclap, and nuchal rigidity. Subarachnoid hemorrhage presents with a sudden, severe thunderclap headache, often described as the worst headache of my life. Nuchal rigidity, neck stiffness, is a classic finding. CT head is the initial diagnostic test. Gradual onset suggests a different etiology, e.g., migraine. Focal deficits may suggest an ischemic stroke or mass lesion. Question 10. A 55-year-old male presents with chest pain radiating to the jaw, diaphoresis, and nausea. The 12-lead ECG shows ST segment elevation in leads V1 V4. Which intervention is the priority? Option A, administer morphine 4 mg 4. Option B, administer aspirin 324 mg chewed. Option C, prepare for emergent percutaneous coronary intervention, PCI. Option D, obtain a chest X-ray. The correct answer is option C. Prepare for emergent percutaneous coronary intervention, PCI. This patient is experiencing an ST segment elevation myocardial infarction, STEMI, indicated by ST elevation in anterior leads V1 V4. The priority is rapid reperfusion, the goal is door to balloon time of 90 minutes or less for PCI. While aspirin and morphine are important adjuncts, they do not address the underlying occlusion. Chest X-ray is not the priority. Door to needle for fibrinolysis is 30 minutes if PCI is not available. Question 11. A patient with a DNR, do not resuscitate, order is in cardiac arrest. The CEN should: Option A, start CPR immediately. Option B, confirm the DNR status and not start CPR. Option C, call the family for permission. Option D, ask the patient's primary nurse. The correct answer is option B. Confirm the DNR status and not start CPR. If a patient has a valid DNR order, advance directive, the healthcare team should not initiate CPR. The CEN should confirm the DNR status before withholding CPR. If the DNR is not immediately available, the CEN should initiate CPR unless the patient's status is known and documented. The family's permission is not required if the DNR is valid. Question 12. A patient with thyroid storm presents with fever, tachycardia, and confusion. Which medication is used to reduce thyroid hormone levels? Option A, propylthiouracil, uracil, PTU. Option B, methimazole. Option C, propranolol. Option D, all of the above. The correct answer is option D, all of the above. Thyroid storm is managed with medications that block thyroid hormone synthesis, PTU or methimazole, and beta blockers, propranolol, to control symptoms, tachycardia, tremors, hyperthermia. PTU is preferred because it also blocks the conversion of T4 to T3. Cooling, 4 fluids, and dexamethasone are adjuncts. The CEN should anticipate ICU care for these patients. Question 13. A patient with a severe asthma exacerbation is not responding to continuous bronchodilators and systemic steroids. The CEN should: Option A, administer magnesium sulfate. Option B, prepare for intubation. Option C, administer Heliox. Option D, administer epinephrine. The correct answer is option B. Prepare for intubation. Refractory severe asthma may progress to respiratory failure. Magnesium sulfate is a second-line treatment that may help, but if the patient is in impending respiratory failure, exhaustion, confusion, silent chest, intubation is needed. Heliox is a rescue therapy for some patients but not first line. Epinephrine may be given for anaphylaxis but not asthma. Question 14. A patient with a suspected globe rupture should: Option A, have the eye patched and the patient placed NPO. Option B, have the eye examined with a slit lamp. Option C, be given 4 antibiotics. Option D, be discharged with a follow-up. The correct answer is option A. Have the eye patched and the patient placed NPO. Globe rupture is a surgical emergency. The eye should be patched with a shield, not pressure, to prevent further injury. The patient should be NPO for possible surgery. Ophthalmology consult is needed. Slit lamp examination should be done cautiously if a rupture is suspected. Antibiotics may be given prophylactically. Discharge is contraindicated. Question 15. A patient with renal failure presents with fluid overload, dyspnea, and hypertension. Which intervention is a priority? Option A, hemodialysis. Option B, 4-furosemide. Option C, 4-nitroglycerin. Option D, all of the above. The correct answer is option D, all of the above. The management of renal failure with fluid overload includes 4-furosemide to remove fluid, nitroglycerin or other vasodilators to reduce afterload, and hemodialysis if the patient is not responsive to these measures. Dialysis may be needed for severe hyperkalemia, refractory fluid overload, or uremic symptoms. Acidosis may also require bicarbonate. Question 16. A patient presents with severe crushing chest pain. The ECG shows ST segment depression and T-wave inversion in leads 2, 3, and AVF. This is most consistent with Option A anterolateral STEMI, Option B inferior STEMI, Option C non-ST elevation myocardial infarction, NSTEMI, Option D pericarditis. The correct answer is Option C, non-ST elevation myocardial infarction, NSTEMI. ST segment depression and T-wave inversion without ST elevation indicate NSTEMI, or unstable angina. Inferior leads, 2, 3, AVF, show ischemic changes. NSTEMI management includes antiplatelet therapy, aspirin, ticagrelor, anticoagulation, and possible PCI depending on risk stratification, Grace score. STEMI requires emergent reperfusion, while NSTEMI is managed with a more nuanced approach. Question 17. A patient with a spinal cord injury at the C5 level is experiencing neurogenic shock. Which findings are consistent with this? Option A hypotension, bradycardia, and warm, dry skin. Option B hypertension, tachycardia, and cool, clammy skin. Option C hypotension, tachycardia, and warm, dry skin. Option D hypertension, bradycardia, and cool, clammy skin. The correct answer is Option A. Hypotension, bradycardia, and warm, dry skin. Neurogenic shock results from loss of sympathetic tone following spinal cord injury above T6, leading to unopposed parasympathetic tone. This causes hypotension, bradycardia, and warm, dry skin, vasodilation. This is in contrast to hypovolemic shock, cold, clammy, tachycardia, and cardiogenic shock. Treatment includes 4 fluids and vasopressors. Question 18. A patient with a suspected myocardial infarction has a cardiac arrest. The ECG shows ventricular fibrillation. After the first defibrillation attempt, what is the next step? Option A resume CPR immediately for 2 minutes. Option B administer epinephrine 1 mg for. Option C administer amiodarone 300 mg for. Option D check a pulse. The correct answer is Option A. Resume CPR immediately for 2 minutes. After defibrillation for VF/pulseless VT, the ACLS algorithm directs an immediate return to CPR for 2 minutes, 5 cycles, before checking the rhythm and pulse. Epinephrine is given after the second shock. Amiodarone is given after the third shock. High-quality CPR is essential for outcomes. Question 19. A patient presents with a panic attack, shortness of breath, chest tightness, and paresthesia. The CEN should. Option A apply a paper bag to rebreathe CO2. Option B provide reassurance and instruct the patient to take slow breaths. Option C administer a benzodiazepine. Option D perform an ECG. The correct answer is Option D. Perform an ECG. Chest pain and shortness of breath in any patient should be evaluated for medical causes, ACS, PE. An ECG, vital signs, and appropriate labs should be done. While panic attacks are a common cause of hyperventilation, the CEN should not assume this without ruling out life-threatening conditions. If organic causes are ruled out, reassurance and breathing exercises are helpful. Question 20. A patient presents with a wound that is dirty, deep, and contaminated. The CEN should. Option A irrigate and debride the wound. Option B close the wound primarily. Option C leave the wound open. Option D apply a pressure dressing. The correct answer is Option A. Irrigate and debride the wound. Dirty wounds require extensive irrigation with normal saline to remove debris and bacteria. Debridement of devitalized tissue is essential to prevent infection. Primary closure may be delayed primary closure, to allow for drainage and monitoring. Pressure dressings are not the primary treatment. Tetanus prophylaxis is indicated. Question 21. Which assessment finding indicates spinal shock? Option A, loss of reflexes below the level of injury. Option B, muscle spasticity. Option C, hyperreflexia. Option D, autonomic dysreflexia. The correct answer is option A. Loss of reflexes below the level of injury. Spinal shock is a transient condition following acute spinal cord injury characterized by loss of reflexes below the level of injury, flaccid paralysis, loss of sensation, and bowel/bladder dysfunction. This phase lasts hours to weeks and is replaced by hyperreflexia as spinal shock resolves. Autonomic dysreflexia is a later complication. Question 22. What is the most common dysrhythmia associated with acute myocardial infarction? Option A, atrial fibrillation. Option B, ventricular tachycardia. Option C, ventricular fibrillation. Option D, premature ventricular contractions, PVCs. The correct answer is option D. Premature ventricular contractions, PVCs. PVCs are the most common dysrhythmia seen in acute MI, often indicating myocardial irritability. While ventricular tachycardia and ventricular fibrillation are more dangerous, PVCs are more frequent. Atrial fibrillation can also occur but is less common. Reperfusion therapy and antiarrhythmic management are key strategies. Question 23. A patient presents with a peritonsillar abscess with a hot potato voice, trismus, and drooling. What is the priority? Option A, 4 antibiotics. Option B, and consult for possible incision and drainage. Option C, steroids. Option D, CT scan of the neck. The correct answer is option B. And consult for possible incision and drainage. A peritonsillar abscess presents with a muffled hot potato voice, trismus, difficulty opening the mouth, drooling, and a unilateral bulging tonsil. It requires prompt evaluation for possible incision and drainage, IND, or needle aspiration. 4 antibiotics and steroids are adjuncts. Airway compromise is a risk, so airway management is the priority. A CT scan may be done to confirm the diagnosis but should not delay end consultation. Question 24. Which law requires screening and stabilization of patients in the ED, regardless of ability to pay? Option A, HIPAA. Option B, EMTALA. Option C, OSHA. Option D, ACA. The correct answer is option B. EMTALA. The Emergency Medical Treatment and Labor Act, EMTALA, requires that anyone coming to an ED must be screened and stabilized, regardless of their ability to pay. This applies to all hospitals that participate in Medicare. Patients cannot be transferred without being stabilized, unless medically indicated. EMTALA ensures access to emergency care for all. Question 25. A patient with a known abdominal aortic aneurysm, AAA, presents with sudden onset of severe back pain and hypotension. What is the priority action? Option A, obtain a stat abdominal CT. Option B, prepare for emergent surgical repair. Option C, administer 4 fluids to restore blood pressure. Option D, obtain a 12-lead ECG. The correct answer is option B. Prepare for emergent surgical repair. Sudden back pain and hypotension in a patient with a known AAA is a ruptured AAA until proven otherwise. This is a surgical emergency. Immediate surgical consultation is the priority. CT may confirm but should not delay surgical preparation. 4 fluids should be given cautiously, permissive hypotension, to avoid increasing bleeding before surgical control. ECG is not the priority.